get started. So my name is Hannah Gully, and I am on the Patient Advisory Board of Dysautonomia International, and it's my pleasure to be introducing Dr. Glen Cook today. So, yeah, applause, that's good. Very nice. So Dr. Cook is a neurologist, a clinical neurophysiologist, and an autonomic specialist at the Naval Medical Center in Portsmouth, Virginia. He completed his autonomic fellowship under Dr. Goldstein at NIH before completing his neurophysiologist fellowship at Walter Reed Medical Center. We learned this weekend that Dr. Cook just opened up the newest autonomic lab in the United States, so that's awesome news. Thank you so much. So please give a warm welcome to the newest member of Dysautonomia International's Medical Advisory Board, Dr. Cook.
Thank you, Hannah, and thanks for the chance to be here today to share with you. As Hannah mentioned, we did just open what should be the country's newest autonomic testing laboratory, the second autonomic testing laboratory within the Department of Defense, and we are officially open as of June 28th. And so we're glad to see those capabilities expanding in the country as a whole, but obviously I have a specific interest within the Department of Defense. In that regards, I should say that nothing that I say today reflects the opinion of the DoD, the Department of the Navy, or anything else that your tax money are going to. I spoke on this topic 2 years ago at this conference and did an informal poll, and I'm going to repeat that here today. Obviously not scientific and obviously biased by the fact that you all chose to come to this talk, but I want to show of hands how many of you personally had the onset of symptoms of dysautonomia after a concussion or traumatic brain injury. Okay, and how many of you had worsening of symptoms of dysautonomia that you already had after concussion or TBI? Okay, so I'm seeing a fair number of hands go up. Obviously, you're folks who chose to come here, so biased sample, but I think it gives some idea of the fact that this phenomenon happens. We're going to talk today about why people might have symptoms of dysautonomia after traumatic brain injury, and the mechanisms that we're going to talk about really are theoretical. These are ideas of why this might happen, and these ideas are not mutually exclusive. More than one of them can occur in any given patient, let alone between different patients, and they all remain subject to be proven or disproven. So we're going to talk about how those things can happen. We're going to talk about what actually happens to the brain after a traumatic brain injury, and we're going to talk about how we can use this information to treat concussion, whether or not there's a component of dysautonomia. And I want to highlight the crossover between the way we treat concussion and the approaches that we use to treat symptoms of autonomic dysfunction. So when we use the word concussion, what do we mean? I mean, the English word just means a blow or a force, right? But when we're talking about this medical diagnosis of concussion, we're talking about some structural or functional change that happens in the brain because of the transmission of some mechanical force. So the brain can be disrupted physically, mechanically, something that you might be able to see on imaging or under a microscope, or simply functionally. That is, the actual structures of the neurons and their supporting cells remain intact, but their function is altered. And both of those can occur. Concussion is a subtype of traumatic brain injury. So traumatic brain injury has various classification systems according to its severity, typically mild, moderate, or severe. Because I'm in the DoD, I usually use the DoD's criteria for grading those. There are variations between different authors and how they might group things. For our intents and purposes today, concussion is mild traumatic brain injury. And again, the semantics, different people might quibble about how those terms are used, but for the most part, they are synonymous. It's important to remember that you can have a concussion without losing consciousness. So I've had plenty of colleagues, either in their professional role or as parents, have mostly their kids get knocked out on the athletic field. Kid gets knocked out playing soccer, gets up, and coach says, "Oh, go back to play." And the parent goes, whoa, wait. Hey, this kid's clearly concussed. And coach says, no, he's better. Or the kid is clearly wobbly. Maybe he didn't lose consciousness. And the coach says, no, he didn't lose consciousness. Therefore, he didn't have a concussion. So the public education message here is you don't have to have loss of consciousness to have had a concussion. And this is a common thing. Lots of us take blows to the head in our activities of everyday life, often involved with athletic events, and that's perhaps why children and adolescents are more exposed. When we look at concussions alone, it's in the realm of 1.5 million per year. And we talked about that grading scale. And what's important to note is that, and not all TBI grading scales include negative imaging in the category of mild traumatic brain injury, but the majority do. So to qualify for mild traumatic brain injury, your conventional neuroimaging has to be normal. So normal CAT scan, normal conventional MRI. If you have some type of abnormality that appears to be due to that traumatic force to the head, then it automatically puts you in the category of moderate traumatic brain injury. So mild traumatic brain injury, aka concussion, your CAT scan, your conventional MRI is normal. And so that means that as a neurologist, if you come into the emergency room and the ER docs call me about your case, I don't have any way other than your clinical presentation to tell you whether or not you truly had a concussion using our standard medical techniques. So I use your history. We talk about the symptoms that you're having. And here's a list of what many people with concussion experience. And I've seen at least 4 times during this conference a list of symptoms that people report accompanied with POTS. You probably recognize that the lists are quite similar. So we do a neuroimaging. This is a CAT scan. Someone with a concussion, their CAT scan is not going to look like this. So there's clearly something wrong here. This is obvious, easier to diagnose, may or may not be as easy to treat. But what about this kid? This is a boy in Afghanistan who's being treated by one of our hospital corpsmen. He was playing, tripped, fell into a ditch, cut the top of his eye, got a little dazed and confused. If you put him into the CAT scan or the MRI, his brain's going to look normal, regardless of what his symptoms are. So what methods can we use to better detect the changes that can occur in the brain with concussion? Well, one thing that we can do is diffusion tensor imaging. This is a special MRI technique where we look at the white matter tracts of the brain, and we make the computer give them different colors according to the direction that those white matter tracts are traveling. This is a fairly time and computing and labor intensive task at this point. This is not standard medical care. This is still a research activity. It creates beautiful pictures. And it's because of these pictures that we've been able to document disruption of these white matter tracts. So the white matter are the myelinated neurons within the brain. These are the connecting pathways, the pathways that connect different areas of cortex. And there are different ways that we can image that. And oftentimes, if in the cases in which we see greater amounts of white matter tract disruption on diffusion tensor imaging, we can see accompanied changes in special MRI techniques that have now become standard of care, where there are small pockets of blood deposition. Whether or not we would categorize an MRI like this as mild or moderate has now become somewhat debatable. This is a technique that 6 years ago probably wasn't in widespread use, but now this susceptibility weighted imaging is in more widespread use. And if we saw these collections of blood that we know match up with traumatic axon damage, is this someone that you would call mild or moderate TBI? We would still go based on the old classification, but we would assume that someone with this degree of evidence of traumatic axon damage is going to have a more significant brain injury than the person who doesn't. And so why does this occur? This can happen simply because of the forces delivered to the brain. So you can imagine if someone pummels me in the head, those mechanical forces are going to be delivered to the brain. And those white matter tracts that are fixed to some extent are going to have these forces applied to them laterally. And that can create a shearing force that directly disrupts those axons. So you can have a direct disruption. And that may certainly be the case in a lot of people, particularly in moderate and severe TBI. But we've learned that many people don't have a direct axonal shearing effect after their traumatic brain injury, but rather the axons die off after their brain injury occurs over the next couple of days to weeks. What happens when a neuron takes a significant mechanical force is a change in the ion flux across the cell membrane of that neuron, and there's a cascade of events that ultimately results in an overwhelming release of calcium within the neuron that then causes that axon to die off and retract backwards. And we can see that pathologically if we dissect a brain and look at it under a microscope, but that may also be a significant component of the axon damage that we see on newer and research-based imaging modalities. So why does it matter if those white matter tracts get disrupted? Well, as I talked about, those are the communication pathways between different nodes within the brain. You may have heard during this conference or even beforehand about the central autonomic network. So these various places in the brain that are primarily responsible for the autonomic or automatic functions of the body. And all of these areas of the brain, these gray matter structures, are connected by white matter tracts, some of which are more important, or we think are more important than others for autonomic functioning. Structures like the uncinate fasciculus. The internal capsule is one of the huge highways within the brain carrying information from one place to another. Well, what happens, what could happen when you disrupt those? So if we imagine those white matter connections between the orbital frontal cortex and the amygdala and those brainstem structures responsible for sympathetic outflow, if you disrupt those white matter tracts, your sympathetic outflow is likely to be disrupted. And these arrows probably should be bidirectional, or these could be the central connections, because it's not just a top-down communication, but there's also a bottom-up communication where information from the autonomic nervous system and the resulting functions of the body also feeds back into the brain. So it's not just an output problem, or the problem could be not just an output problem, but also an input problem, that the information is not getting back to these centers like the orbital frontal cortex and the prefrontal cortex. So that's one way that you could have symptoms of dysautonomia after concussion, is that these downstream and upstream pathways are simply being disrupted. So the information for, say, blood pressure control or heart rate control isn't getting down to your blood vessels or to your heart, or the information about your heart rate or blood pressure is not getting back up to your brain because those white matter tracts have been disrupted. So there's one idea. So here's another idea by which autonomic symptoms might arise after traumatic brain injury, and that comes from the hypothalamus. So the hypothalamus is the master endocrine gland of the body, or it's not gland, the master endocrine control block. The endocrine system are those glands that release hormones, and the hypothalamus controls all of those. It has direct and indirect connections to the pituitary gland, and we recognized years ago that after more severe forms of traumatic brain injury, hypothalamic pituitary dysfunction can be disrupted. And if we look at people that have had severe TBI and follow them out over the couple, 3-6 months after they have their injury, up to about 60% of them have measurable alterations in hypothalamic pituitary function. Some of that can occur directly because of hypothalamic injury. While the hypothalamus does sit pretty deep in the brain, it does lie pretty close to the bony floor of the skull. The other way that can occur is because of disruption to the blood flow to the anterior part of the pituitary gland. And both through autopsy dissection of the pituitary gland and through imaging evidence, we've seen that a lot of cases of hypothalamic pituitary dysfunction after TBI is associated with infarcts, damage to the cells from lack of blood flow to the anterior pituitary gland. So it happens a lot in the more severe forms of TBI. So how often does it occur after concussion? There are numbers published by one group that up to 11% of people have measurable alterations in hypothalamic pituitary dysfunction after concussion. And this is just using pretty standard laboratory tests of endocrine function. Now, does this mean that everyone after a concussion needs to have endocrine testing done? That's not standard of care at this point, but it definitely should raise the level of awareness that some people's symptoms after concussion might be due to hormonal problems and not necessarily directly to the effect on the brain itself. So a lot of you raised your hands when I asked the question, how many of you had worsening of your symptoms of dysautonomia after a concussion? And that's something that I've definitely seen a lot in my own clinic, that someone who already has problems with POTS and or fainting, faints and hits his or her head, or has some other event where there's an injury to the head, and the symptoms get a lot worse. And I use the analogy of the three-legged stool. So if you have a stool that has 4 legs, it's going to be pretty stable, right? All the chairs that you're sitting on have 4 legs. But if one of those legs is damaged, let's say you have some underlying damage to the central or peripheral functions of the autonomic nervous system that puts you at risk for POTS or syncope or other symptoms of dysautonomia, you've still got 3 legs on that stool, and the stool can still stay upright. So that the 3 legs form a plane, and that stool can remain balanced. But then if something else happens, like a concussion, breaking one of the other legs of that stool, suddenly that stool is not standing up anymore. So you've heard a lot about autoantibodies at this conference, and I think you all recognize and appreciate that this is something that is still under investigation. And the same applies to autoantibodies related to traumatic brain injury. Like I mentioned earlier, we don't have a marker for the diagnosis of concussion. So we would like some biomarker that tells us whether or not a concussion has actually occurred, some imaging tests, some laboratory tests. And there's been a lot of work on laboratory tests that could potentially detect concussion. Some blood test, maybe even some salivary test where you could say, hey, here's something that we found in the blood or the saliva that we don't normally see in people's blood or saliva that we know matches up with concussion. And we actually have certain chemicals, mostly these are proteins that we look for, that can be looked for in blood primarily, that do fit with even mild traumatic brain injury. So if you have a traumatic brain injury, and let me just say these proteins that are detected in the blood, this is still not standard of care. This is still on an ongoing research basis. So we've got these proteins that we know we can detect after concussion. What happens when proteins that aren't normally circulating in the blood suddenly are circulating in the blood? Well, we could theorize that there's the potential that an autoimmune response can then be mounted against those proteins. One of the proteins that we look for associated with concussion is one called GFAP, glial fibrillary acidic protein, and one group has documented antibodies against this protein in people after TBI, and similar work has been done by other groups saying that, hey, perhaps in some people there is the development of autoantibodies against cerebral proteins after TBI. Now, what does that mean clinically? We don't know. We don't know if that then contributes to the symptoms of TBI and possibly to the symptoms of concussion after TBI. That might contribute to any dysautonomic symptoms after TBI. So what do we do when someone has a concussion? Well, the first thing that we want to do is not worsen that neurometabolic cascade that I showed the picture of earlier. So we want to keep the brain rested. We don't want to put it under greater metabolic demands. So physical and cognitive rest. It is, I can tell you clinically, when someone says, well, doc, what does that mean that you want me to rest my brain? That is really hard to gauge. But usually I tell people that means no Xbox. That means no violent movies. It means no strenuous academic work. It means staying relaxed and getting plenty of sleep. We think that keeping the brain from being knocked around again is important, and we have evidence to support that. Makes sense. It's good that we have evidence to support it. Hydration seems to help people. And it's important for people after a concussion to let those around them know what's going on. That becomes important in my line of work, where I'm taking care of young soldiers, sailors, and Marines who then need to let their command know what's going on. And along with the metabolic rest that we need to give the brain, you want to avoid chemicals that might put the brain under chemical or metabolic stress. And then after a period of rest, we slowly return people to physical and mental activities. And the stairway there is meant to depict that graded return to physical activity. So if we're talking about an athlete or a soldier or a sailor who has physically demanding activities, we don't put them right back in at 100% right away, but we give them a chance to step up their activity every couple of days or so, and we track how their symptoms are doing. But tracking symptoms can get a little hard, whether you're treating an athlete who is motivated to get back in the game and isn't going to be necessarily forthright about his or her symptoms, or the soldier or sailor who's anxious to get back in the game and get back to his or her job in the military. They might cover up those symptoms that they're having. No, doc, I'm fine. Just put me back out in the field. And then we have the corollary concern, the occasional person who might be milking their mild blow to the head for all it's worth. And no, let me stay in bed for a few more days and just keep reading quietly, because that's better than having to go do my job. Some people might use that as well. So how do you how can we, in some more objective fashion, return people to their physical activity in a graded and intelligent fashion? And one way that we might be able to do that is by using measurements of heart rate variability. So this is the tracing that you see here is a pretty standard heart rate to deep breathing test that many of you in this room have had done, where a person breathes in and out deeply, and we track the heart rate and look at those changes in heart rate with deep breathing. So every time we breathe in, our heart rate goes up. Every time we breathe out, our heart rate goes down. If that isn't the case, then we know that that's a problem. And we can measure that heart rate variability with deep breathing. We can measure it at rest. We can measure it with exercise. And if we look at heart rate variability after a concussion, there are about 15 papers in the literature that have pretty consistently shown alterations in that heart rate variability. They've all used a variety of methods, either looking at heart rate variability directly. More often, they have used what's called a power spectral analysis, looking at the changes in heart rate variability within specific frequencies. And what's come across most consistently is that the changes in the lower frequency variations in heart rate is what we see altered after concussion. And those changes actually persist for weeks and even months before gradually getting better. So about 15 papers in the literature, probably about 10 of those looking at power spectral analysis of heart rate variability. And again, pretty consistently showing changes, but all of the numbers of individuals studied in those papers is pretty small. So a lot of work still needs to be done to take this information, apply it to larger populations, and then look at how we can actually use it clinically. Because at this point, all we've said is, hey, we see those changes there. How can we use it clinically? Now, if you look at what's in the literature in regards to autonomic dysfunction and concussion as a whole, if you take out severe and moderate traumatic brain injuries, so those more severe injuries to the head, and really just look at concussion, the number of papers in the literature is a lot smaller. Most of them focus on this heart rate variability that doesn't seem to have a clinical correlate to it. So we see these changes in heart rate variability that persist long after people have become asymptomatic from their concussion. So how often do people have a concussion and have symptoms of dysautonomia? Again, we don't know the answer. One of the earliest reports in the literature was published by Dr. Grubb and his group, and they had a patient who developed POTS after a concussion. And subsequent papers have really been single patients or 3 patients, very small case series or individual case reports that said, hey, here we have a young athlete who got concussed and then developed POTS or developed syncope. Most of them don't have much follow-up. Those that do have the patient has gotten better. There is one paper that looked at 34 people with post-concussive symptoms that were persisting for 3 months or more, so what we would call post-concussion syndrome. And they took these 34 people and put them on a tilt table, and I have to remind myself of the numbers of how many they saw. 24 of their 34 patients had syncope or POTS on the tilt table test. So again, this is a concussion group that said, hey, all of our patients with these persistent post-concussive symptoms that kind of overlap with what we see in our POTS patients, let's put them on the tilt table. And 24 out of those 34 had POTS or syncope. Well, they repeated their testing at 3-month intervals, and what they saw was that as the symptoms of concussion went away, what had been labeled their persistent post-concussive symptoms, as those symptoms went away, the POTS went away and the syncope went away. And they had 3/4 of the patients in the period that they followed up, 3/4 of their patients actually did get better. And again, their hemodynamic improvement, that is their improvement in heart rate and blood pressure problems, corresponded with their symptomatic improvement. So that's really the only study that we have that says how many people with persistent post-concussive symptoms might have some measurable dysautonomia. So a lot of work remaining to be done in this realm. So we talked about how axonal injury can occur, either through direct forces or through that metabolic cascade that then injures axons. And we talked about how the disruption of axons can affect the central autonomic network. We talked about how hypothalamic pituitary dysfunction could potentially give autonomic symptoms after TBI. And we talked about the idea of autoantibodies being created after concussion, and we said we really don't know if that has anything to do with symptoms at all after concussion. And we talked about that graded return to activity. And so just one other thing to say on that graded return to activity, I think we see the same thing, or at least we take the same approaches when we're treating POTS and syncope, in that we don't ramp people up to 100% right away. So after someone has an onset of POTS, we take a graded approach to their physical therapy and to the return to their normal function and duties. Oftentimes people have setbacks, and we may or may not know why their symptoms worsen for a period of time. But after that, we again take a graded approach to get that individual back to their previous baseline. We don't ramp people up right away. So there definitely is an overlap in the way that we approach the therapies of concussion and dysautonomia. And we talked about the heart rate variability changes and what we have seen after concussion. And we've highlighted the fact that we really haven't figured out yet how to use those changes clinically to help us guide people's treatments. But a lot of promising things within the field, and one of the nice things about looking at heart rate variability, blood pressure alterations after concussion is that these are things that can be done relatively easily and without invasive testing. So you're not having to lie in an MRI scanner for 2.5 hours getting the images done for diffusion tensor imaging. You're sitting there hooked up to an EKG for 10 minutes, maybe 20 minutes, maybe 30, and you do a little bit of exercise to see how things are. But a lot less, maybe a lot less technology and time intensive, certainly for the patient at least. So those were some of the things that I wanted to share. Let's open up to questions. Dr. Schofield?
What's kind of the average and the range of recovery times of these people with post-concussive syndrome?
Right. So if you take the average person after concussion, 90% of, it depends on what numbers you quote, about 90% of people get better after a week. there are other studies in the literature that say, hey, maybe the rate of recovery after a concussion isn't quite as high as that 90% that we've historically quoted, but maybe a lot higher number of people have persistent post-concussive symptoms. I don't know that that's totally true, because I've seen a lot of people get concussed, and like 90% do fine and get back, they're dazed briefly, but they get back to what they're doing pretty quickly. For those that have persistent post-concussive symptoms, it's probably about 80% of them, and this is just my gestalt from our TBI clinics and my general neurology clinic, over the next 2 to 3 months, get better and get back to their duties. But what about that lingering 20% of the persistent post-concussive syndrome patients that just go on and on having problems of dizziness and headaches are the big complaints. And then right behind that, difficulty sleeping, difficulty with attention tasks. And I don't think we have good numbers to say what happens to those people long term. So I can't really tell you how long it takes those people to get back to their regular routine, because they don't. I think I have the full study in my suitcase right over there. They were looking at the 3 to 6 month mark. They did follow some people out to a year, but it was kind of in that 6 month-ish mark that people were getting better. So, yes.
How many patients have you ever, the ones who were slow to recover and went on to develop POTS, is there any studies to see how many of them maybe did have a lower level of POTS prior to the concussion, that maybe the concussion exacerbated?
Yeah, we have no idea. Okay. So those case studies and those case reports, they say that the patient was fine until head injury happened. The majority, if I recall right, there was one that said patient had some episodes of syncope before, got concussed, and then became significantly worse. Dr. Stewart?
What happens to blood pressure? You alluded to blood pressure instability, I think you said.
Right.
In these patients. And is it related to heart rate?
So I actually don't think we know what happens. I probably have about 3 patients with post-concussive symptoms where we've tilted them, and I have recordings. So we need to tilt. I think what we have seen is we need to tilt a lot more. I can say the ones that we've tested in our laboratory up in Bethesda, people who have had persistent post-concussive symptoms, and we ask the question, hey, do these people have a dysautonomia? And we've tested them. They've been normal, or we had one guy who had pretty significant decrease in his heart rate response to deep breathing, but he also had a lot of other stuff going on medically and cognitively, emotionally, and pharmacologically. Yes.
I have an 18-year-old daughter with POTS, having the symptoms before, but with 2, possibly 3 concussions at this point, they spiral things out of control. A year ago, I took her to a brain center in Texas where they had functional neurologists, and after 4 days we walked out and the POTS was gone. Within 2 to 3 months, it did return, but and they were actually doing huge studies on veterans with concussions to try to help them. So what's your experience with the functional neurology?
So I would ask, well, what did they do there that made her better?
It was a bunch of heebie-jeebie stuff. They
Yeah.
put her in this machine that would spin her and whatever. I can't explain it, what I watched, but I watched
Okay.
them do tilt table each day, and each day the symptoms, her heart rate symptoms got better.
Yeah, not knowing what they did there, I couldn't tell you. I do know that our National Intrepid Center of Excellence up at Walter Reed Bethesda, that brings people in for a week or two at a time for a comprehensive, integrated TBI treatment. And they're usually taking people that have had recurrent traumatic brain injuries or moderate to severe traumatic brain injuries. They're doing a lot of imaging and other research studies, but they're also doing a very holistic approach to treatment. People coming out of there feel a lot better. To some extent, I wonder if that's just because they've been given a period of prolonged rest and relaxation that has made them feel better. And these aren't patients with symptoms of dysautonomia, but a lot of them come out of that experience reporting that they feel a lot better and that their symptoms have improved significantly. Again, is that really because of any one or combination of the treatments that are there, or simply because they're put in an environment where they're allowed to rest and to heal? I don't think we know. Yes?
When you talk about mechanical injury to the brain, would that include seizures?
No, unless the seizure is causing the person to hit their head. So when I'm talking about mechanical injury to the brain, I'm talking about the direct physical force. So something hits me in the head, that physical force is transmitted through my skull to the tissues of the brain, injuring gray matter structures, but probably we think more importantly, actually causing shearing forces of the axons and actually directly damaging the brain. And that's opposed to the metabolic changes that occur in the brain after a traumatic brain injury, in which that there are alterations of receptor function and ultimately increased calcium release within the axon that then causes damage. We do know that at least generalized seizures are very metabolically stressful events to the brain.
The person I'm representing has POTS that her cardiologist thought was secondary to something else. And she participated in a clinical trial where magnetic seizure therapy was used to try to address treatment-resistant depression. So very brief seizures under a minute, under anesthesia, repeated 3 times a week for 6 weeks. She swears that that's when her symptoms of POTS began. Does
I-
that sound like?
I don't know. I mean, we use electroconvulsive therapy for refractory depression and for a few other conditions fairly regularly, but I've not seen any cases, and I've not seen anything in the literature about POTS or other dysautonomia arising after electroconvulsive therapy. Right. Ma'am.
Yeah, you had mentioned the diffuser tensor imaging.
Mm-hmm.
I was just wondering, like if you had had a concussion, let's say when you were, 7 or 8 years old, and you were now 23, would that pick that up? That particular test pick that up? And if it could, where would one go to get that kind of?
Yeah, I think the answer is probably not. I think it would depend on the degree of injury. I think the other important thing to remember is that concussions are actually really common. I grew up. I was a kid once, and I definitely had more than one concussion. One that landed me in the hospital overnight. I guess I turned out somewhat okay. And now that I've got kids of my own who are growing up, I definitely have seen them get concussed, and it's like, all right, well, let's let you take it easy for a day. And for the most part, people bounce back from concussion, and definitely there is a gradient of injury. A lot of the injuries that end up enrolled in studies are the more severe ones. Even though we lump mild traumatic brain injury or concussion together as all one thing, there's definitely a very wide spectrum in there. So the person who gets hit on the head and just feels dazed and has a little bit of a headache for a day and then is better, that's obviously a very different injury than the person who gets knocked out for 2 minutes and is confused and wobbly on his feet for 3 hours and then is having difficulty sleeping and headaches for the next month. That's a very different injury, even though we call them both concussion, mild traumatic brain injury. There's a very wide spectrum in there. The other thing that I think is important is the metabolic state of the brain when the injury occurs. How well rested is the brain? What nutrients are available to the brain? And I use that very broadly because we don't know what things are important. But if the brain has already taken some type of metabolic stress, and then you add the concussive force on top of that, it's reasonable to think, and clinically we have, I think most people would agree, that those people do worse after concussion.
Yeah, because I'm trying to figure out if there's a connection between, if I look, my daughter's 23, if I look back at her symptoms of, dysautonomia, and if I look back at that young, which she started developing symptoms even that young, like she had, and we don't know if it was concussion, but she had a hit
Mm-hmm.
to the face by a hockey puck, which, she was at school, we had no idea what happened. But it seemed like, well, after that, things started happening. So I've always wondered, gee, is there some connection to that?
Yeah, was that the start of things? And those are hard questions. And a lot of you raised your hands when I asked how many of you had symptoms that started after a concussion. We really don't know how often dysautonomic symptoms are triggered by concussion, but it's a story that we hear often enough to say that, hey, in some people, a concussion does seem to be the inciting event. So, sir.
The study you mentioned at the end, were 24 or 34 people.
Right.
So is the conclusion from that when the effects of the concussion abated, that the hot symptoms abated as well?
Right.
And so I had a situation sort of like that where I thought it was a big nine, she had a concussion hit by a car, and the imaging was negative, but from that point forward was dizzy, brainish, foggish. She functioned, but it continually got worse with latency and stuff like that. And so it seemed like the concussion symptoms never really abated 13 years later.
Right.
Is there a way to, when we forget the pot symptoms for a minute and assume that concussion, the study says that the key thing is to kind of reverse the effects of the concussion, or is there a way to do that, or is it just
Yeah.
too far down?
So I think definitely where you're at is, we would say, is too far down the road. The metabolic changes after a concussion are really resolved after a month, and to a great extent, a concussion has run its course within a couple of weeks. There are things that we can track that have changed out to a month. And so, but at that point, the concussion is really done, and then you're left with the effects of the concussion through whatever mechanism those effects might be arising.
Would it be, would it be unusual for the effects of the concussion to last 15 years?
I think that.
At this point, has it just evolved into something else?
Right. I think that's a question that we don't totally know how to answer. We definitely see people that have concussions that for some reason have symptoms that persist months and years, and we don't know why. And we have, if we look at people who have a concussion, we know there are certain physical and historical traits that can help us predict whether or not they're more likely to have persistent post-concussive symptoms, but we don't know how to predict that very well, and we don't know what to do about it to prevent those from happening, other than the thing that we do for everyone, that is letting the brain get rest and that graded return to activity. So that would be like one of the holy grails of concussion medicine would be identify those people that are more likely to have post-concussive symptoms and have some intervention that you can give them, whether it's some therapy or extended rest or some magic pill that improves metabolic activities of the brain through, I say magic pill because we don't know what that missing link is for people as a whole, and it's probably different for different people. So.
Have you seen anybody in your clinic who has a POTS or a dysautonomia, either with or without concussion, like get better and be able to fully return to duty and do the PT test and do their job to the fullest extent?
I have seen people get back to doing their jobs and doing what they want to do. I've seen people be able to salvage a military career after they've had documented and diagnosed dysautonomia. Percentages, I guess I could probably look back at my clinic spreadsheets and tell you what percentages have actually gotten there. But to a great extent, it depends on what has caused that person's dysautonomia. Because again, remembering that even POTS itself is a very heterogeneous condition. And so it comes to asking, well, why? Why is the person having these symptoms? And then addressing that why and getting them back to where they want to be.
Now, as DOD to DOD, is there a way that I could retrain into something else? Job-wise, medically?
Yeah. So the answer is it depends. It depends. Yeah.
So like this may be something that I don't even know if they're even thinking about or talking about. But like my husband and I, we follow like the studies on like the CTE and like what happens to the professional athletes and stuff like that. So you talked about the proteins that they're looking at, you know, potentially being in your bloodstream. Are you referring to potentially the same proteins that they talk about for CTE? And do you know of any, I know that there's not a lot of studies that go long-term for POTS patients at this time, but how they talk about the early onset of dementia for CTE patients, anything?
Yeah. So the question is regards to chronic traumatic encephalopathy, CTE, which is, if you've not heard about it, a phenomenon that we see in people who have had recurrent concussions and even more moderate and severe brain injuries, that over time they develop what we've come to recognize as a pretty typical mood and cognitive disorder that on brain biopsy is associated with the accumulation of a very specific protein, a protein called tau protein, in certain areas of the brain. And in specific areas that we don't see accumulation of that protein in other neurodegenerative diseases. So it seems to be a very specific neurodegenerative disease associated with recurrent traumatic brain injury. And we've seen that both in boxers and NFL athletes. And you can imagine that the DoD has a big concern about this and is doing a lot of research in this realm because of the number of people that we have who have recurrent brain injury. What is the overlap of that with these proteins that have been shown to show up in the bloodstream after TBI, and the proteins that have had autoantibodies associated with them after TBI? The answer is we don't know for CTE. Tau is, we know is released after brain injury, and we can detect that in the blood. And we also look at some of the breakdown products of tau, and that can be a marker that we use to track brain injury on a research basis. I don't know of anyone documenting any autoimmune basis for that, and I don't think we have anything at this point that implies an autoimmune basis for chronic traumatic encephalopathy. Is there any link between POTS and CTE, or POTS and a neurodegenerative condition, or POTS and long-term dementia? I don't think we have any evidence to say that there is. Ma'am?
Are you able to accommodate pediatrics in your lab at Naval?
We do, but only if they are military healthcare beneficiaries. So yes, we do.
In your region,
Okay.
a physician in your region, and we just have not had a pediatric lab, we have to send up here.
Right. So we have tested. We will test people down to 8 years old. If there are people that are younger, that we can make arrangements to try other things. We don't have, even for younger adolescents and children, we don't have normative data for a lot of comparisons. And children, depending on the situation, may or may not be able to cooperate with a lot of our testing. But we do test children and adolescents. Yes, ma'am.
So, you don't, your clinic doesn't, they do testing but not treatment. So if you're part of the DOD and you want to have your child treated, you just say, I'm just not sure if I'm with the right doctor.
Okay. Well, and I can just, from what do we do at Naval Medical Center Portsmouth? What capabilities do we have there? So our lab, we'll take referrals from primary care doctors, cardiologists, and we will do. Sure, we'll take referral. We'll and just like just like the other testing that we do in our EMG lab and in our EEG lab. Anyone who is TRICARE Prime can be tested in our lab. We do have an autonomic disorders clinic, and I say we have an autonomic disorders clinic. I am the autonomic disorders clinic. So again, and that is open to TRICARE Prime beneficiaries. All right. Well, thank you all for letting me share today. Appreciate it.